Hello again, I'm Matt McGarren. I am the acting chief of the Community Engagement and Integration Services. Here are our homeless programs here in Los Angeles. I've been here for about 4 months. I want to introduce a couple of people, although Mr. McKendrick left. Mr. Robert McKendrick is our executive director starting next week in our program. When he comes back, I'll point him out. But I also want to introduce Dr. Reddy. Dr. Reddy is our clinical director for our clinical programs, which I'll describe a little bit as we go through this presentation. And I also want to introduce Ms. Maggie Lowe, one of our social workers. And her position is called a coordinated entry specialist. And I asked Maggie to come because this is a very important part of our cooperation with the city, which Heidi was speaking about, and where Dr. Bamber had asked questions about veterans getting identified in the community. Maggie is the job is specifically to help identify those veterans when they touch points in the community. If you're experiencing technical difficulties, please stand by. So, Dr. Reddy, we have the numbers for the gap analysis we still have from last year. So Dr. Reddy will talk through the numbers about our gap analysis and the strategies that we are to fill those gaps. So she'll go with that, and then I'll go over the different components in our program and how we address each one of the needs that our veterans have.
Hi everyone, I'm Reddy. I am a primary care physician. I did a master's in the science of health services, so I am going to try to explain the differences between our gap analysis and LAWSAS. Let me know if you can't hear me or if I need to repeat. I am not a methodological expert, but we did really partner with LAWSAS to get to the bottom of some of the differences, so I'll try to talk through those as effectively as possible. Hopefully the slides will be up when I get to the actual numbers so that you can see where we've identified specific gaps and where we're hoping to get to with those. Okay, so in terms of the methodology that LAWSA uses, it's slightly different than ours. LAWSA and Melanie Mertens from LAWSA is here, as well as our veteran officer, and so she'll be able to speak to the specifics if any questions come up. But they use homeless inventory counts, and they use other methods and counts that are slightly different than the VA's analysis. So when they did their analysis, I think we saw some numbers just recently up on the board showing a gap of about 703 emergency shelter beds. And when we sat down with LAWSA, the data team also to review that, we also looked at our gap analysis. And so when you look at our gap analysis for the VA, we utilize the PIC count. We also utilize our homes and HMIS data, and we pull that together with some other additional resources from HUD to start to understand better, not just the current inventory and the current counts, but also the trajectory. So we look at inflow and outflow, and we try to develop predictive models to better understand and get at what we're looking at in the coming years. We use the analysis to really get to not just does the person have a place to sleep, but are they permanently housed, and how do we get to the point where they have the capability to be permanently housed. And then another key definition difference, I think, we don't have emergency shelters in our definition. We do have transitional housing. We do work to make that same-day access and that capability to provide transitional housing as a resource for emergency purposes, with the goal that veterans will be able to be permanently housed during their time of transitional housing. So we have different compartments for different types of housing that we provide, and we do look at how to house veterans based on what their specific needs are. So the first area is chronically homeless veterans not eligible for VA health care and who need permanent supportive housing. As Heidi said, it's about 10% of our veterans, 360 options as they work through that housing to permanent housing. There is actually no current gap based on our flow, our capacity, and how we are addressing the needs in the community. Based on the second criteria, chronically homeless veterans eligible for VA healthcare and in need of permanent supportive housing, this looked at not just how many vouchers we have, but how successful we are at utilizing those vouchers, and how successful are we at keeping veterans housed in permanent supportive housing. And that actually is something where we currently have a gap. Based on our utilization, based on our retention in VASH, we currently have a gap of 1,239. If we looked at the numbers, and if we can utilize those VASH vouchers more effectively, which we're working to do, and we'll get to that in a minute, and if we can keep veterans housed in those VASH apartments, we'll actually be able to close that gap completely. The third row looks at episodic and short-term homeless veterans who need rapid rehousing or other interventions. So this might include our transitional housing programs, our grant per diems, our SSVF, our domiciliary care, and so for this category, actually, we do currently have a gap. So one of the things that is actually crucial in our efforts is our work with SSVF. Veterans that are able to receive those subsidies are often able to maintain housing, and so our SSVF teams are actually ramping up their service provision, and so that's one area that we're actively working on. With that, and then with additional occupancy of our domiciliary and our grant per diem programs, and then additional work to improve our positive exits to permanent housing, we'll be able to close that gap. And so even though it's a large number, this is cumulative, so this isn't like the point in time count, this is actually a projection over the entire year. And if we're able to improve our care, improve our provision services, improve positive exits, and work effectively as a larger team with the community and our VA programs, we'll be able to close that gap as well. And then finally, we have episodic or short-term homeless veterans who will actually self-resolve. They might not need any interventions, but again, these might be veterans who are a little more vulnerable, and so we want to make sure we're providing quality services to them as well. So we do track and make sure that that's a population that we're keeping track of. So if you look at that cumulatively, we actually, as we start to work towards some of the solutions we'll be talking through, we will be able to close that gap. And when we look at the analysis, we look at it as a projection over a year. So if we can really, maximize our occupancy and our positive exits to permanent housing from some of our transitional programs and improve our VASH voucher utilization, we could potentially close the gap within a year or two.
So, I want to give you an idea of the current state of how many beds we have available now for homeless veterans. And we have a number of different kinds of programs in our services. And I know you've been here before, but I haven't, so I don't know what you know. So if I'm repetitive or boring or whatever, just stop me and tell me you know this already. I don't know what you don't know. So anyway, we have a number of different housing options for veterans here. And the first one I want to talk about is our VA domiciliary. This is a treatment program. It's called a MHRRTP, Mental Health Residential Rehabilitation Treatment Program. And it is on campus. There are 296 beds that are available for veterans. We are currently housing 162 as of today. We are ramping up our staffing so that we can now, so within the next several months, we're going to be able to have all those beds at least be, potentially be full if we have veterans that are appropriate for that kind of treatment. Within the umbrella of the MHRRTP is the domiciliary care for homeless veterans. So there's 120 beds specifically that are for homeless veterans, and those beds are virtually around 90% full with homeless veterans at any given time. And then there's beds that are specifically for PTSD, and then there's beds for substance abuse veterans. And there's an overlap. Some of those veterans that are in the substance abuse track are homeless veterans, and some of the ones in the mental health beds are homeless also. So they go back and forth between these different tracks. The goal of this program is for veterans to leave this programming to go into permanent housing. And it's a challenge for veterans that are in this program. The program is not very long. It can be up to 6 months. A lot of the veterans don't stay that long. And sometimes they fall into homelessness. They leave against medical advice. They leave for other issues. Sometimes veterans leave and are housed and lose their homelessness, and we end up seeing them back again. So there is some recidivism here. But it's a very intense program, and hopefully we're going to be making it more successful as we go along. The Grant and Per Diem program and our Healthcare for Homeless Veterans, these are community partnerships that we have. There are two different types. Healthcare for Homeless Veterans is a contract. It's just a different payment mechanism, but it's shorter term too. Healthcare for Homeless Veterans, usually they stay about 6 months. With the Grant and Per Diem program, which is a grant-funded program that's administered through the VA, this veterans could stay in the Grant and Per Diem program for up to 2 years. And this is an important program for us because this is where the veterans that have other than honorable discharges can go. If they're not eligible for VA health care, they can go into this Grant and Per Diem program and they can stay in this transitional housing for up to 3 years. This also has the goal of permanent housing from being discharged from this program into permanent housing, and we're about a 65% successful in that with those programs. Then we have our VA supported housing, our VASH, which is technically it's a HUD VASH. It's a partnership between Housing and Urban Development and VA supported housing. The VA doesn't provide the housing, as you've heard. The VA provides support to the veterans through case management, social work service, mental health services that wrapped around the veteran when they are in their home. So we go out and visit, depending on the acuity level, the intensity of the need of the services, we go out and visit veterans in their home and provide services there. Currently we have 7,300 vouchers. Of those, 4,890 are housed. We also have project-based vouchers. This is this number right here. Currently we have, so project-based vouchers is what it sounds like. It's a project that is it's more of a closer proximity living as opposed to a tenant-based voucher, which is an apartment housing community. A project is a contained area where veterans and other homeless persons will live in more of a congregate living. And we currently have 692 vouchers that are being used for project-based vouchers, and we're hopefully going to have 691 more vouchers available for project-based vouchers this coming year. It depends on our developers whether they get their structures finished and they're ready to take veterans on. So this is a prediction. This is our hope. Although I've been told hope is not a strategy, but it is our desire then to have this done. And then there's a number of veteran-specific apartments in the community, which we don't necessarily case manage or manage these programs. We do, or we are aware of the veterans that are in the community that are run by other entities that are veteran-specific but are not under our supported housing program. So we talked about this yesterday, so we might get a little repetitive here, but just to talk about the Bridge Home again, this is a new endeavor for us. This is, our emergency shelter bed's going to have 100 beds, 2 tents of 50 veterans each, and our expectation is to have those beds full. We have a admissions fair. Do you want to ask a question now? Okay. So we're going to, on the day it opens, we're going to start admitting veterans into this program. And our hope is to have the 100 beds full within the first several weeks of when this program is open. We have not yet identified a service provider for this contract, so we want to have their agreement before we start deluging them with homeless veterans. So we'll work on that, but we want to shelter veterans quickly. And when they're in there, we're going to start moving them from day one, be screened for our supported housing vouchers or for some other transitional housing opportunity for them. This you all heard yesterday, that when Rob was giving his presentation. So, the contract, the service will start 45 days after the selection is announced. The eligibility male homeless, eligible for VA health care, able to perform daily activities of daily living. The reason we say that is because this is not a medical facility, this is a shelter. We expect that the veterans will be able to take care of themselves in the shelter. We'll be there to offer support, we'll be able to assess medical needs, we'll be sending a medical staff there to assess and determine whether they need a higher level of care. But generally, we expect veterans to be able to perform the activities of daily living.
Yeah.
So in the shelter, veterans will get their own bed and a locker and a dresser. They're going to be 3 meals a day. The case management ratio that we're hiring from our service provider is 20-to-1. So that means for every 20 veterans, there's going to be 1 case manager assigned. So there's 5 case managers on site from the service provider, and that is in addition to our VA services. We have 3 contract liaisons that are going to be very involved with this program, and we also just have our regular outreach and social work staff that will go there on a regular basis. The services provided are life skills groups like money management, anger management, life skills about how to move into permanent housing. So 85 to 100 veterans within the first week after it opens is ambitious. We would like that, but we do have to get the agreement with our service provider. We'll do it within the first couple of weeks. I'm pretty confident in that. The veterans get referred by a number of different resources. We already know some identified veterans that we can ask. Somebody had mentioned them driving up to the VA today on San Vicente. There's a veterans out that are camped out near our fence. This will be an opportunity for them to come in. We have a number of other veterans in encampments that we will offer this opportunity to. I want to make it clear, though, that this is not, we can't make veterans come in. This is not something that we can compel a veteran to do. Hopefully, because it's on campus, because it's attractive, and because it's in a place where services can be wrapped around the veteran, that it'll be appealing to veterans to come in. So that's well, we will find 100 veterans to come in. The veterans get oriented, they move in, and immediately we start screening and referring to other resources. But the intention that within, and Heidi mentioned this before, that from the screening time to the actual being housed with a voucher takes about 90 or 95 days. That is our intention here, is to even reduce that further. But we're looking at the outside of 90 days from veterans when they come in. If eligible, if appropriate for permanent housing, they'll be in permanent housing within 90 days. They can stay up to 6 months. That's in the service contract, but I don't believe that that's necessary. I believe that 90 days is appropriate. So Dr. Reddy's going to talk about one of our pilot programs we're going to do to better utilize our vouchers, better utilize our outreach teams, so that we can find all the veterans that we need to find.
All right, so for our pilot project, we're actually looking at this in partnership with LASA. Our team, Maggie's been representing at daily huddles with the LASA team, and so we've really been able to combine forces, and ultimately that is what will be required to make a dent, as we have talked through. It's a relentless job, and so in order to make any sort of a headway, we really are looking at these partnerships and taking advantage of every single one. And so I think this pilot really exemplifies that. We're starting in SPA 4 because it is the SPA with the SPA service population area. So there are 8 spas in LA, and you can see on the map right here. SPA 4 is actually right in the middle. It represents our metro area, and we, at the last pit count, we had about over 1,000 of our homeless veterans in that spa. And so when we look at opportunities, that's one where we see a fair amount of opportunity. We also have a little capacity with our VASH teams to be able to permanently house in that area. And we have some PPVs or project-based voucher units coming online in that area as well fairly soon. And so I think that's a really prime area to start a pilot. We look at really expanding this pilot because we expect it to be effective. So as we ramp up this pilot project, we're looking at sustainability and expansion as we go. And so I'll talk about the different segments of it, and if you have any suggestions or comments, at the end, we'd love to hear those as well. So our current team involves members from our PHAs, our city, LASA, the county as well, and we're looking at pulling in our project managers for each of the individual project-based sites.
What's a PHA?
PHA, Public Housing Authority, so PACLA and LACDA are examples of that. And so the biggest piece of this is really understanding our veterans, understanding where they are, what programs they're already engaged with, what they're interested in terms of their priorities, and then available resources to really affect permanent solution. And so what we're doing is working closely with LASA, working closely with our National Program Office to finalize a by name list, which is a list of veterans who could use engagement and coordination of services, identify exactly where that where the individual veterans are located, and start to effectively case conference. So case conference with our VA providers, case conference with our community providers, and ensure that any linkage, if possible, is maintained and seen through to effect. So we're starting with that identification, and simultaneously we are also optimizing our outreach engagement. So our outreach program we're reorganizing it to be a little bit more proactive and engaged and linked to our HMIS permanent solution. And so all of our outreach teams are starting to co-locate with their VASH partners within the individual spas. So we're starting with SPA 4, and that's going into effect. And so that, in addition to case conferencing around individual veterans, will help us to expedite a veteran's process from engagement and out in the community to VASH vouchering and housing. The next step of this is really to coordinate with our project-based sites. So we have, as Mr. McGarren mentioned, we have a lot of sites coming online. We want to make sure that we flow into those sites with our veterans getting housing and vouchering simultaneously to that site coming online. So that is something where there are several steps involved. We're working on coordinating that effectively with our public housing authority partners and with additional community partners as quickly as possible. Because there are so many steps in that process, and sometimes some of those steps can take a moment, we often lose chances to engage with our veterans, and I think that's what makes this process so challenging at times. And so we're looking at how to maximize efficiency, cut steps back, but also get through all of the steps that the veteran needs to get them into a VASH voucher or another permanent solution. And then I think that, the next step and the last step really is about processing fares, and that's part of this efficiency. So we're looking at, as we start to identify veterans, we start to prepare their packets for submission to our public housing authority partners. Do we need a processing fare to expedite any bottlenecks that we might see? And they've been really present at the table during these LASA huddles every day. We are working with them consistently, not just at the huddle level, but also individually. And so we are starting to see some headway, some transparency, some data sharing, and it's a promising step in the right direction. Again, this is a process that's incredibly challenging for me. I would have the number of forms, when I saw how many forms it takes to get somebody through to get them into one of those VASH voucher departments, it's difficult. And so I think, it takes a lot for our veterans to get through the process. It takes a lot for our VASH teams to support and engage through that process. So we're looking at every option to simplify that entire stream.
Thank you. I think one of the things I'd like to point out is that has really been effective when in other homeless programs I worked across the country in Tampa, Florida, and in Philadelphia, is this by name list. So this is something that has not been optimized up to this point. Maggie has taken the lead on this, and the by name list is to where we can identify in each one of these spa areas, identify the homeless veterans by name. So when we know their names, we know who they are, we can outreach them better. We'll have a list of every veteran by name and what service they would need. And this is where we utilize our community partners, we utilize our county partners, our city partners, the sheriff's department, the city police, emergency services. We have our vet centers. We are having discussions with all of them, so anytime they meet with a homeless veteran, they let us know. And we can put this person on a by name list, contact them, and then provide whatever services that we can at the time.
The area of priority for us is our female veteran population. We often find that our female veterans have a significantly different set of needs and an incredible vulnerability that puts them at a high priority expedited through any housing processes, and we're on the same page there. So I think we're really looking for collaboration across this. I look at Melanie from LASA and see that, our stakeholders, our community partners are really there front and center helping us with this effort. So what we've done to date is one thing I would like to go through, and then at any time, we want to make sure that communication is flowing, because we don't always know when we're going to be able to engage with a female veteran and ensure, or any veteran for that matter, ensure that they get the services that they need. So we do have our contact information at the end of the slide. If you're having any issues getting someone connected and through services, we do want you to feel free to reach out. But let me go through what we're currently working on. We're collaborating with our partners within the VA, so we have ongoing discussions and initiatives with our women's health team, our emergency department, domiciliary transitional housing program, and our outreach teams, as well as our community partners, to really identify and prioritize our female veteran population. We're trying actively to align our population with the resources that are out there and available. So we are consistently and currently working on our VASH process for female veterans. We're making sure that we expedite them and put them at high priority through the processing process. We also look to expedite the transitional housing referrals and their domiciliary screening and admission as well. And then the other thing that we're working on actively is we've identified from by name list the female veteran population, and we have gone through individually and looked at that population to see from that list of individuals who can we actively engage with, who are we already engaging with, and how can we expedite the process towards permanent housing. So that's something we're actively working on. We are working with our outreach team to prioritize our female veterans because of the amount of vulnerability that they experience on a daily basis. And so again, anytime there's a community partner that has a veteran who could benefit from any of the resources we have, we're encouraging that prioritization from them as well, and feeling free to pick up the phone and give us a call.
So yesterday, the question came up about our strong structure here and why they're only male beds at this shelter here on campus. So we do have capacity for female beds out in the community. Our DOM has 17 beds specifically for female veterans, and those beds are full right now. But in the community, there are 65, or we have 9 different community partners that do provide female veteran beds. Specifically, 65 beds total in the community, and there's 50 beds full now. So there are still 15 vacancies in the community for female veterans right now. So the community beds are not 100% utilized. So I just want to make sure we had those numbers for your benefit. So here's our contact information. And I'm ready for questions.
I think Dr. Bamberger was first up today.
Hi, Dr. Reddy. I'm Josh Bamberger. I'm the HPAC doctor in San Francisco. And one group that we didn't describe in your gaps analysis, which is a big thorn in my side, is the people who are too sick for HUD-VASH. You have dementia, chronic alcoholism has led it so that the HUD-VASH team feels that they're not going to be able to live independently, but they're not sick enough for a skilled nursing facility, or they don't want to go into a skilled nursing facility. There's no beds in the CLC. What are you guys doing down here for that?
So that's a good point. I was just speaking with our mental health department just last week about this, and the terms the LA terms are different from the Philadelphia terms. If there's assisted living facilities in Philadelphia and Tampa, here there's things called IMDs or IMDs over there.
Yeah, IMDs are people with mental health disorders,
Right.
instead with medical problems. So dementia that falls outside of IMDs is a problem.
Sure, that is true. And so we work with our social work department, and they're looking to expand their capacity for more contract nursing home beds for veterans that might have dementia. And also those IMD beds for veterans with mental health disorders that can't be maintained in either our grant per diem or on their own in their supported housing program. So we're working on expanding our capability in that area.
Again, you didn't describe the gap, which is
Yes.
people who shouldn't be in nursing homes or can't be in nursing homes. So you described expanding your nursing home beds, which is great.
Yes.
But there are people between those things.
That's a good question, and we don't have that gap.
that's not well captured in the actual gap analysis. I don't think that sometimes the medical diagnoses aren't fully captured, even with that cognitive impairment is not always coded effectively, so it's hard to pull that into this type of analysis. We have a lot of experience where we've been working with veterans who are not quite ready. They don't want to go to a nursing home or a boarding care. They want to live independently, and up to the point where it's really almost impossible. You've thrown every sort of advantage at them, whether it's aid in attendance or home care or whatever it might be. That's what we're looking at. It's for those individuals who are almost at that point. We have a lot of nursing in HUD-VASH, in our HUD-VASH program for that reason. We have NPs that will be out in the field or also there for consultation. We have OTs in the field as well, and we go through the intake process so that our HUD-VASH team is as equipped as possible to take on some more vulnerable veterans. And we believe that that's really, they want that opportunity, and we try to allow that as much as possible. At that point where they really, despite every opportunity and every advantage and everything that any resource we have available, it's still not enough. That's where we have active conversations with the entire care team. So whether it's HPAC, whether it's our inpatient doctors, whether it's our HUD-VASH team in general trying to advocate, we really feel like that's the conversation that we all have to be having collectively. So we have a consult service that we initiated in the hospital that we use for that purpose. We have our occupational therapists will go into the hospital and advocate with the veteran. And we've had our domiciliary team and our HPAC team go out into the field with some of the more incredibly vulnerable cases as well. So we try to look at it in a way that's really collective, and we found that that's the best way to approach it.
That's great. You mentioned board and cares or residential care facilities. To my knowledge, the VA has no strategy to fund that level of service. Is that your experience here in Los Angeles?
I don't know that. I mean, yes, you're right, the VA does not fund that kind of care. Usually that's funded through the individual veteran when they go into that care.
Right, but $1,000 a month ain't gonna do it. Not in LA, not in Fresno.
Yeah, I agree that it's a shortcoming, and it is something that needs to be addressed.
I just want to highlight that. It's not meant to be critical, it's meant to be that there's this group that are using tons of our resources. They're in and out of the hospital, they get transported all the time,
Yeah. The VA has a program called the Medical Foster Home Program. It's administered through social work, where the veterans go into a home and they're basically fostered by the home that's been trained to handle the medical problems of the veteran who goes in there. It's not as utilized as, I don't know how well utilized it is here, but I know in other VAs that it is not the first line of defense in this area.
And I just have one different question, and then I'll stop. Stop me anytime, because I know I'm using way too much oxygen in the room. But getting back to the bridge housing, the sprung structure, the decision to not allow female partners of male veterans to be able to live with their partners has been made. What are the policies that influence that decision? And is there any movement that can be made in those policies so that men don't have to decide to be indoors with their partners, outdoors with their partners, or indoors without?
So the policy for that, mostly it's because of the space, the way it's configured, that these are single beds for single people. And so we wanted single male veterans rather than cohabitating male and female veterans in the same structure. That's the main reason for it.
I'd be happy to sleep in a single bed next to my wife rather than leave her on the streets.
Right, but then there's 99 other men in the room too.
Yeah, there are lots of men who do, who are worried about sexual assault and men sexually assault men. Do we really know that this is a problem? Again, rather than debating the issue, the question is, where's the decision being made, and is there any movement that could potentially be made with recommendations from the Secretary of the VA?
I'm conferring with my. So the structure, the decision for the structure, how it was developed, was made before I was there, and I'm checking with Dr. Reddy to see if she knows the answer.
We can take that question and you can give us feedback.
Yeah, why don't we do that? That's
Feedback, once you comment where you want to go. Okay, good. across the aisle to Mr. Perlich.
Just a comment as an owner who's trying to rent to veterans and a veteran myself. As far as VASH vouchers go, in addition to the pricing issue of the voucher, one of the issues is your responsibility to your other residents of having the same standards for screening. And I think that scares a lot of owners. We have a building in San Bernardino. We have 40 VASH vouchers in. And one of our frustrations is if we have a bad actor, the services are not as good as advertised, and not knocking the VA's commitment, but it's lack of resources. So I'm really speaking to the gap between the number of VASH vouchers you've issued and the number of veterans who can't find housing with them. And one of the practical issues for an owner is even though if he wants to rent to veterans, he has a moral responsibility to the other residents. And if the VASH voucher standards are different from a norm, there's another barrier to accepting veterans. And I know it's a different issue, but to the degree that the VASH voucher residents have higher acuity, it makes it harder for owners like us who really want to be part of the system. It makes it more difficult. And, you know, we're the low-hanging fruit. So, and there are other owners who would never do it regardless. So it's a different issue, but I wanted to just say that it's something you may want to take a look at, because to the degree you can get the veterans in the normal population, one of the things you may want to take a look at is what the rental standard is for non-veterans. And you may have some veterans in there that qualify, and to the degree your VASH vouchers are taking higher acuity, then you create an issue where it's harder to get owners to.
That's true, and that is a problem. That some of the landlords that are available to rent to veterans with the VASH voucher are maybe timid of maybe the experience they may have had in the past. So you describe things like maybe there might be violence or there might be substance abuse. And some actions that veterans take will get them discharged from the program. And of the veterans that we have in our program now, only about 10% of our veterans do get discharged for those reasons. And so I think that it's, and I don't know your personal experience with this, but I think maybe that 10% is louder than the 90% that do well. So their landlords might become timid because they hear about those 10%, but the vast majority of our veterans that go into VASH housing do well and are appropriate and are regular citizens, and they survive and they succeed, and that is the case. But there are exceptions.
Yeah, and a follow-up comment. We have also project-based Section 8, where we implemented the preference to rent to homeless veterans on the waiting list. And when we get vacancies, we work with two nonprofits, and we can't get a veteran, a qualified veteran in there in time to rent to them. So we've been holding vacancies and not being able to rent. So we get problems with those.
And we do have our case managers, our social workers going into the veterans home depending on the acuity level. So we do an acuity scale. We have an intensive phase of, then we have a more moderate phase, then we have a ready for discharge phase. And at each different phase, the veteran gets a higher number of visits. Depending, the higher the acuity, the higher number of visits and support that the veteran gets.
Okay, we'll go Stanley, Allman, and for Mr. Zimmer. I bet you suffered from that Z a lot.
Used to it.
Used to it. I apologize.
Christine Stanley, I had a question with the DOM and the wrapping it up to build the beds. Are there more discussion to make more than 17 beds for the building?
We haven't had that specific discussion, but it's not off the table. I'm sure we can consider that when we're ready, when we have the staffing for the rest of the other beds. Yeah, certainly we'll consider that.
And then the 9 community partners that you mentioned you have relationships with, is there a way to get access to that information, or do you?
The list of the names? Yeah, we can give you that.
And then the last question I have is this meeting that draw for a pilot, who's the contact and how do we know more about that or participate in it?
You can contact me, but, and Maggie Lowe is actually, I can always link you up with her, but she's the one that's attending daily and sort of helping to strategize more collectively with our community partners.
I actually know. Fantastic, thank you.
Anthony?
Anthony Allman for the record. If we go to slide 5, with the housing types and the beds. The title says, VA Greater Los Angeles Healthcare System Bed Capacity Program. Is this for the whole VA Greater LA catchment?
Yes,
So this is not specific to LA County?
correct.
Okay, so, yeah, I think that skews things a little bit in terms of availability, right? I mean, as opposed to looking at the LAHSA information, which is specific to the
Correct.
continuum of care.
Yes,
Right.
that is one of the,
Right, so that's, I think, one of the issues we keep having, just in terms of looking at the local homelessness authority and their region and, the overlap.
For the gap analysis or for just in general?
These numbers right here, right? So this is for the catchment area. The gap analysis information was specific to LA County?
So we actually, when we met with LAHSA and we worked on it, looking at it iteratively, we actually did look at it by GLA and catchment area to make sure that we weren't comparing apples and oranges. And so when
Okay.
we did that, we actually found that the numbers are similar, but I think one of the critical differences too is that a lot of our grant per diem partners don't put their data into the homeless inventory count, and that homeless inventory count is what LAHSA uses to then extrapolate for their analysis. And so there's a critical piece there that was missing as well. So when we looked at the same coverage area and when we incorporated the homeless inventory count, they actually agreed that the gap was closed.
So the idea being because the GPD partners, VA is paying them, they're mandated to report in the system as opposed to LAHSA where they're not getting paid by LAHSA to provide the service. So, why do the extra homework?
yeah, well, the grant per diem partners are supposed to provide data to the HMIS system, which is the system, the database for all homeless persons in the area. And
Does VA here use HMIS or do they use
we use homes.
Right. Right, so, I mean, that's an issue, I think
That's another issue, yes.
That's a huge issue, right? Because you're dealing with two different,
Well, so that's why we meet with our community partners so that we can reconcile that data.
That's what I wanted to ask as a follow-up question. Is that why there's a duplicate by name list? You mentioned that recently GLA has created a by name list?
No, it's the same by name list.
Okay. it's
Yeah,
the
so
same.
that's what Maggie does that with LAHSA and I.
No, it's the
No.
same by name list for,
Yeah.
it's just a collaborative effort
Yeah.
between the VA.
You've got to use the microphone, please.
No, we just have the one by name list for Los Angeles County. It's a collaborative effort between the VA and our COC in Boston.
And your name?
I'm sorry, my name is Maggie. Maggie Lowe.
Thank you.
Do you think the general concept of VA matching its HMIS system to the local homelessness authority is just way more complicated, or does it help you at the local level deconflict data?
Are you asking whether I think it should be more compatible?
Yes.
I mean, yeah, I think it would be great if it was more compatible.
I guess taking a step further, do you think that VAs across the country should adopt the system that their local homelessness partner is using?
That's a little above my pay grade.
Conceptually.
I think
Conceptually.
any way we could reconcile the data so that we're all speaking the same language would be helpful. Whether HMIS is better than homes or not, that's not really,
Right.
but if it was one, my personal opinion, if it was one database that we could access, that everybody accessed the same names, the same situations, the same addresses and all that,
Yeah, I mean, I think it's just a huge issue of the federal government versus dealing with the, you know,
Right,
the
it's a
various local
kind of our
partners.
issue with our medical health records, talking to DOD records too.
Okay, Mr. Zenner and then Letitia.
Jim Zenner for the record. We have a lot of conversations as it is being a partner, but just raising some community concerns that I've heard, and as I was here at VA, we were working to address. But first question: how many beds are located in Skid Row, and are there plans to increase more beds down in Skid Row? The work that is done through the Welcome Center, often we could get veterans placed outside of Skid Row, but very difficult to place in Skid Row. So I just want to check.
I'm gonna have to get back to you about the number of beds in Skid Row. I know we have, at least one of our grant per diem providers from Volunteers of America is down on Skid Row. Is that correct? Yeah. So we have vacancies, that beds are available there. Our grant per diem programs usually run about 80% full on any given day.
And are most of the occupancies outside of Skid Row? You guys have the data breakdown on that?
That would take a little bit of doing to get that, but I could get back to you on that. I don't have that with me now.
And then as far as being able to, the setup before you can access VASH through the community and not have to come to the VA, communities recently told me that that's not the case. Can you speak through that process and what the decision making was behind making it to where you had to go to VA? Because the benefit out of the community, you could go, there's providers that aren't, you don't have to go all the way to West LA or downtown. And so the community is I've heard from some of the communities, that's a little bit of a difficult.
So the current process is that, an individual would engage with one of our VA providers or our community partners, and would be somebody where we might flag that they could take advantage or benefit from a VASH voucher. And so then from that engagement point, we would then go to a referral for a SPDAT, which I forget what the full name of the SPDAT, but it's an assessment tool. From that point, if they are somebody who might be eligible for VASH, they would go to one or VA partner. If they were eligible for SSVF, they go to another. So I know you know that process quite well, but I'm just going through it so that people understand the numbers. From there, we do a VASH screening, and then from the VASH screening, we do intake, where we align with all the documents that are necessary. And so what you're speaking to is we skip that VA intake process completely, and the community partner or a VA provider out in the field could just bring them through to the processing piece.
Correct.
Okay, so we're not trying to eliminate that piece completely, because there is some value during that screening process. There's also a biopsychosocial assessment. There's also that ability to engage and pull them into other resources and opportunities that are available from the VA. But what we're looking at is ways to streamline that and make that more veteran-centric. And so that is something that we're looking at actively and trying to figure out what we need to do to make that easier for the veteran. I mean,
Great, yeah. And last question is recruitment of care beds. There's been rumors that we're bringing on recruitment of care beds here locally, and I didn't hear that brought up in the conversation, and was wondering if you guys could speak to that.
Those recuperative care beds that they were talking about, they don't fall under my area of knowledge. I know that we talk about that through our mental health care beds. Do you know more about the recuperative care beds, Ron? We have.
So there's HCHP recuperative care beds. There are some in VOA Los Angeles. The partner we have 40 beds they have between their safe haven and their recuperative care. On site, we don't have anything formal at this point.
Sure, thanks, Dr. Reddy. Robert. I think we're at
Here, I can-
Rob Merchant, for the record. This is a need that Dr. Reddy has brought forward to us as a healthcare system, and we are looking at it, Jim, yes. And one of the reasons that we're looking at it is because it also affects the inpatient flow in the hospital itself, when we do have people who would normally be eligible for discharge, but are not ready to be discharged into an independent living situation. So yes, we are looking at that.
Great, thank you.
and looking at ways we could do that on an accelerated basis.
Great.
It works out. Can you remind me, logistical shuttle, can you remind me, the VASH vouchers, when a veteran is matched and moves into a unit, does, the VA pay for all move-in expenses, including like any necessary, like basic living supplies that the veteran needs, towels, sheets, pots and pans, and then also, well,
So we don't pay for the move-in directly with the, we do have a lot of donations. A lot of our community partners will donate move-in kits for veterans that will have, you do that?
Yeah, MVets does that.
Yeah, and that's that, right. So they'll provide move-in kits that will have towels, sheets, and all kinds of things like that, to make the move-in easier.
so it's not an allowable expense, in your opinion, do you think it should be, to support the veteran? And is there any advocacy that could be done by this board to do that? I mean,
I'm not sure,
know that-
I don't believe we're allowed to give out items from the VA itself. We get them through donations, and then they're done through donations are through our voluntary services, and then they're provided for the veterans.
That includes furniture? Like if they need a
Sometimes.
bed? Like, so if you're not able to get a donation from an agency and you have a veteran moving into an apartment and there's no bed,
So there's a program nationwide that's called Vets for Vets, that's run through our grant per diem program, actually, that's donated, and I don't remember the organization that's doing the donation, but we do, that is available to veterans on a case-by-case basis.
I guess just to follow up, in terms of to try and recruit more landlords, is there any kind of damage mitigation fund or holdover unit program that could be developed or that's being explored at all? I know at the county level it's something we've done, and it's encouraged the number of people, landlords to accept vouchers. Is there anything comparable on the VA side?
Not that I'm aware of, not through the VA, but I know that this is a discussion I was having with the city about whether there could be some sort of incentive for the landlords to rent to veterans for just that reason. If that was the fear, was that was gonna be some kind of damage from a unit. But it's still in just the thought experiment process. Are we finished because they're done?
We have Ms. Stanley, and this will be last question.
Okay, I'm not in a hurry.
Yeah, well,
Super fast, I'll talk to you more about SSGF, because they can provide
SSGF,
those,
sorry.
utility, like a bed and possibly a refrigerator, and, some other, expenses that are associated with it.
okay, very good. So it's a dead giveaway when all the batteries on the mics are starting to fail. We've had a very active morning. And so I appreciate you, Matt, and the CERS team. Dr. Reddy, Ms. Lowe, thank you so much for coming over.
Thank you, and feel free to contact us if you have any specific questions.
Okay, very good.